Hello, so I'm Dr. Darren Edwards, and the title of my talk is From Protocols for Syndrome to Process-Based Therapy. So when we're referring to protocols for syndrome, we're referring to the DSM model. That's very broad categories. And when we're referring to process-based therapy, we're really referring to the exploration of the dynamic and individual level events that lead up to certain mental health disorders. So trying to personalize treatment for the individual as opposed to relying on very broad and imprecise categories of the DSM model. So my research interests have been around largely acceptance and commitment therapy, which is a third wave CBT approach. This particular talk, I'm exploring process-based therapy because I feel like it's a very important thing for the future. And students on an MSc course in clinical psychology, I feel would really like to do research in this novel area. And the approach is really explaining how the DSM is limited. So a lot of the kind of traditional teaching on a clinical course at MSc level is going to be about the DSM model, how certain approaches such as ACT, CBT, and so forth can be applied given these predefined protocols for syndrome. This is kind of more advanced. This is about how we can actually go beyond that. So the objectives of this talk are to describe the ongoing transition from a nomothetic approach. When I say nomothetic, I mean population level approach of protocol-based treatments targeting latent diseases. That's basically the DSM model I'm referring to there. Towards an ideographic approach of theory-based and process-based therapy. So that's again an ideographic. I'm referring to the individual level, taking the individual and looking at their specific events over time, looking at time series analysis and what are the factors that affect that person specifically. So and then forming more nomothetic approaches. And then number two, to show how this transition can be used practically to target change. And number three, to demonstrate how these are necessary divides of the DSM model are unnecessary, and we can broaden our range of methods available if we accept this more process-based approach. So these are the Bibles of clinical and psychiatric psychology, and the DSM-5 and the ICD-2. The kind of typical criticisms of these models are, number one, they're too clumsy, too little consideration of the individual. I mean, I'm not going to be overly critical of the DSM because it is a good starting point. It does provide us with a standardized way of approaching psychotherapy and providing a way to diagnose and treat individuals. So there's a lot right with the DSM, but we're trying to demonstrate here why we might be able to improve it with a process-based approach. So the second point is, as a criticism, is it's got these arbitrary cutoff points. We know there's a lot of comorbidity. So having these arbitrary cutoff points where, depression ends and anxiety begins is arbitrary, and those who develop the DSM know that. So everyone's aware of the limitations. Number three, the symptoms focus while ignoring etiology. So it's symptom focused and ignores causal factors to disease. Number four, there's poor reliability. So if you've got two clinical psychologists and they're trying to diagnose the same person, one might come up with one diagnosis and another person might come up with a completely different diagnosis because of all these comorbidities. So the final point is there's been too much focus on specific protocols for syndromes and the ever-growing list of these things. So just as an example of the kind of problems, what I'm referring to with comorbidity. So disease one, You might have generalized anxiety disorder. You're trying to classify someone with this particular disorder, and you are also classifying major depressive disorder. Now, between these disorders, it might be a whole bunch of comorbidity, such as alcohol dependence, OCD, stress, panic disorder, and so forth. So it muddies the water. And we're trying to be, as psychologists, we're trying to be at service to clients. Ultimately, whether you go into academia or whether you go into a professional clinical practice, you're always going to try to put at the forefront of your mind, how can I best be of service to clients? Now, as an academic, what I'm trying to do through process-based therapy is equip therapists and academics, young academics who are interested in this, in terms of how to best navigate this field and how to best develop models. So with process-based therapy, we're really looking at not just the specific latent disease variables of anxiety, which again, we call them latent disease because they're not directly measurable, and depression, and then look at all of these specific comorbid interconnections through complex network analysis. And when I refer to this, I'm really referring to like structural equation modeling and that kind of thing. If you're interested in this kind of thing, there's a reference, Hoffman et al. 2016 below, which I highly recommend. Again, here's a second example of a long list of ever expanding protocols for syndromes. They just get longer and longer and longer, but we've got a limited list of effective strategies. Cognitive appraisal, that's coming from a CBT approach. Cognitive diffusion, experiential acceptance, values, choice and clarification, mindfulness. They're more act-based concepts. Problem solving, coping, emotional regulation. Again, they're more CBT type concepts, but they're all very, very effective. So it's about equipping the therapist with, here are your tools, and this is how to go about it. Again, here's some further reading, as this is only a 10-minute talk. Very quickly about the kind of analysis we traditionally do for process of change. We look at these mediation analysis, where you've got treatment X, treatment Y, the C path, and then you've got the indirect path, the mediating factor, which is basically showing where the variance really lies indirectly. Very, very good approach, but life cannot be this linear. We can't just have isolation, low mood, and rumination. We know people are very, very complex. So what we're trying to do is capture some of this complexity. Now, no approach is going to be perfect. So this kind of approach uses like diary over time, diary events, moods. We try to capture as much information as opposed to just giving box standard questionnaires at 3 points in time. We're looking at maybe 3 weeks of daily data collecting at 10 different times during the day. And we're really trying to capture subtle changes in moods using time series analysis at that ideographic personalized level. And we are developing then certain models looking at which go beyond this kind of linear approach of mediation, which we traditionally do. I've done this approach many, many times myself, towards this kind of approach where we're looking at, okay, isolation, low mood, and rumination might form a mediational relation, but you might have complex things such as low self-esteem bidirectionally related to low mood, low self-esteem bidirectionally related to loneliness, and a relation between loneliness and low mood. So there might be a very specific reinforcing network, a very strong reinforcing network between these. Now, if I identified this through my research data, my advice to therapists, I'd publish a paper, and my advice to therapists is we need to target these complex, these very strong reinforcing networks. So it's less about rumination and more about this. So we're trying to undermine this network and try to lead to more adaptive and reduce the maladaptive processes within the network. So that's exactly what we're trying to do. We're trying to change the network from maladaptive to adaptive. We also want adaptive networks to be self-sustaining. So we want to change the network to be self-sustaining, and we want it to be more adaptive. So to undermine this network using this process-based approach, using the complexity of the data, we might find that targeting low self-esteem with something like cognitive diffusion, and because low self-esteem is going to relate to kind of complex thoughts about yourself. I'm rubbish at this, there's no point me trying. So cognitive diffusion is about that separation of you and your thoughts. And mindfulness, which might target loneliness, because loneliness is more an affective disorder, more of a feeling that you might be going through that period of time, and that might reduce these bidirectional relationships and undermine this mediational process. So low mood might ultimately be reduced for isolation. And we know how important this kind of work is with COVID, for instance, where people have been through long periods of time through isolation. So anyway, that's my research in a nutshell in 10 minutes. I'm sorry, it was very, very short, and it really needs a good hour or two to really get into the nuts and bolts there. But that's my research in a nutshell. I hope to see you guys soon. Thank you very much.